Hey folks, we are back. I'm your host BKP, and it is Friday. We're at Circuit World, and it's time for Ask the Doc with Dr. William Whaley and Raymond Tidman. Now, we have Raymond Tidman here today. I don't know where Dr. Whaley went because the guy I know usually has a tie. Who are you?
Well, here's my tie.
Where's your tie?
Okay, I'm just telling you how devoted I am to this program. I'm not working today. I'm going to L.A. today.
How dare you take a day off?
I know, I understand. I'm going to L.A. today because you haven't been able to travel. I've been to Alpharetta and Marietta, and the guy says, well, what time's your flight? I said, I'm driving. It's Lower Alabama. So anyway, I'm going to an adjacent state
I get
today.
it. I think that's funny because
right.
we talked about that. But anyhow, hey, we always want to thank Georgia Cancer Specialist affiliated with Northside Hospital. We appreciate you for this segment. And yes, greatest Ask the Doc segment in America. Dr. Whaley, how are you?
I'm great.
I'm just glad you're going to the Gulf Coast, LA, because you don't want to go to the Pacific Coast, LA.
No, that's right. No, I'm not going to the Pacific, LA. It'll fall in the ocean.
Yeah.
Well, I think it's appropriate to ask you where we are on the our rain gauge.
Oh my gosh! Yesterday, one of my patients.
I think people want to know.
One of my patients who lives just over here near the Two Wheels Resort, at whatever that's called,
right.
Suches, has a rain gauge in his farm out there. It was 4.2 inches. I think officially we had 2.5, but had 4.2 inches yesterday. We're still down for this month by an inch and a half, and down for this year about 2 inches.
Well, we
were 10 inches
Now,
up
how
last
much did
year.
the lake come up this week?
Well, I just
About 3 feet, didn't it?
I was over there this morning,
Yeah.
and I took a look at it. And I said, "Wow, they filling up the lake." So I sent out a text message to my family. We're going to get the boats in the water here as soon as the last freeze is over. That's usually middle of April.
Well, folks out there nationally or worldwide, we're in Georgia, and as the song says, it's been a rainy couple nights, and I don't think we're done. So anyhow, you always give us
All right.
the update.
Yeah, that's right. I just did. All right, you ready to go?
Yes, I am. I'm always
All right,
ready.
we've got
Good questions.
We've got two good questions here, and both of them have to do sort of with kind of primary care and how you live your life. The first one is, my wife is 60 years old and in excellent health, and she stopped going to her GYN when she finished menopause. Our family doctor saw her for a routine exam and asked about any bleeding, and she mentioned that she had had some blood on toilet paper infrequently. He referred her to a GYN who did a D&C last week, and she has grade 2 endometrioid carcinoma by the biopsy report on the portal. She has not been back to see the local GYN. What do you suggest? Well, I want to stop there for just a couple of things. When I was in training and when I was in the Navy, I used to do locums for family practitioners who went on vacations, and twice I covered the practice of the president of the American College of Family Practice at that moment. And the family doc in that day did the GYN pelvic exams on their patients. When I went in practice in a Mayo Clinic model internal medicine practice where the specialty work is 75% of your practice and 25% is general internal medicine, we did the GYN exams on our patients up until it got to be, I guess, probably the late 70s maybe. So I kind of would like to see the good family practice go back to being a little more continuous.
I think outside of urban areas it still is. I would dare to guess that the majority of Pap smears are done by family physicians in the country.
In the country, yeah. Yeah, so that's the point.
Areas,
the point I'm making there is that this woman stopped going to the GYN, and apparently nobody kind of picked up the ball and ran with it for a decade. So this is kind of easy. Now, she's not been back to local GYN. What do you suggest? The second part of this is, the part I don't particularly like, is she got her biopsy report off the portal, which is an electronic thing where hospital report gets immediately put into the machine, and then it's accessible in many of these practices, and I don't know how to do it myself, but patients can get in and see what their data was. Well, now she's got the thing, and she's got an appointment with the GYN, obviously off a week or two, and so she's, I think, kind of panicked. Wouldn't you say, Ray?
Yeah, you're bringing up a really good point. I've been burned a couple times in my career from being too busy or rushing around, and when you're, I call it the C word, or whenever you're giving a patient really potentially life disruptive information, they deserve to be face to face with you and get their questions answered almost immediately, because I mean their mind goes to places that are appropriately worried, and all these kind of things happen. They can start ruminating inside and thinking about, well, this or that, and to just get it off a computer and see some words, and you go look up the words, and it's not a good thing.
Well, that's what happened here.
Yeah.
Well, and the other thing about this is I don't blame the GYN really, because many times it takes 10 days to get a path report. Yeah. And so if he had scheduled her to come back in 2 days, he wouldn't have had a report. Now, if the hospital processed it quickly and they have a report in 2 days, and he's set her up for a week because of the usual time it takes to get the report, then he's been hoodwinked and messed up by the system, because it got in there in 2 days and she found it too early. Let's get back to the question. Show that first picture, because people don't even know what we're talking about. Endometrial carcinoma. You look like you kind of lost it there, Peter.
Yeah.
All right. Well, this is a uterus, okay?
Right.
And you've heard it, cervical cancer. We talk about ovarian cancer all the time. Well, okay, the inside there is called the endometrium, and that's where the egg implants and the placenta goes, and that's what comes out when women have menstrual cycles. So that is not an uncommon form of cancer, but not near as common as we see with cervix or ovary. Okay, pull that down a minute. There's a clear-cut pathway that they go through here. So what do I recommend? This is going to be really easy. We're just going to pull out this picture. You've seen millions of these. NCCN guidelines, endometrial carcinoma. The problem is this isn't available to the general public, and if they find it, they get confused. So here you got somebody who's done a biopsy, and now they're going to get an MRI or a CT of the pelvis to make sure it hasn't penetrated it. If it's negative, meaning that it's confined to the uterus, and that's what I'm going to tell you that she probably has. Grade 2 is relatively low grade. Then you're going to go right in and you're going to have a hysterectomy. But if any of these tests are positive, you'll see you got 90 other ways to go there, right? So I can't answer how this is all going to turn out for you can pull that down there. I can't answer how all this is going to turn out for your wife, but this is a relatively common sort of cancer. We frequently see it in postmenopausal women, particularly those that have been taking hormone replacement treatment. And that's the reason that you don't stop going for routine exams of the gynecologic equipment when you have gone through menopause. The next question we're going to come to is an 89-year-old woman here in a minute. But somebody has to have the responsibility for kind of making sure that happens. Now, it used to be that they did an annual pap smear on 20-year-olds, and American College of OBGYN and the insurance companies and all that stuff said unless you've got HPV or had many, many sexual partners, you need to have your GYN exams less frequently, but they never said stop them. Now, Ray, what kind of frequency would you say a 60-year-old woman ought to have something done?
Yeah, so I would say based upon your risk factors, and if they've had any abnormal, then you really keep going on with those. The couple of big take-homes, and that's going to be your doc's preference, so I don't want to try to override that, but you shouldn't assume that after you get through menopause that you're out of danger. That's the point. The other very important point is that any bleeding post-menopausal, any bleeding needs to be worked up. And so, and some ladies will think, well, I'm kind of back to going and having periods again. No. If you have bleeding post-menopausal, somebody needs to check that, biopsy that, pursue it. The other thing that's interesting you mentioned there is that my experience with our profession is that if there's a question of a surgeon going in on this kind of case, the GYN oncologists really want to be there. It's just generally not done by general surgeons who do so many other things. But GYN oncology is really a specialized area. Wouldn't you say?
Right. And that's exactly what I was going to say. The question I really asked was, how frequently after menopause, taking if the patient's had anything abnormal, the frequency but if it's a perfectly normal person, they're not taking hormones, because if they're taking hormones, they should be seen more frequently, because there's more things that can happen. If they're off hormones, do they go every year? No, they don't. Probably every 3, I think, is probably pretty decent.
It's pretty decent interval, and it really is dovetailed to the patient. And by that point, most ladies really hopefully have their kind of routines down, and they have a good relationship with their provider.
Yeah, but their GYN's retired, because he would have put them. Just think now. She's 60, so he probably delivered her babies when she was in the 20s. Yeah. He's gotten to the end of and he was older than she was when she was 20 and having kids. He quit. So she fell through the cracks.
That's a very good point. Yeah.
Anyway, so that I think what I think is that women need to stay with their primary care doc, and the primary care doc, in his histories, needs to take that GYN history and make some suggestions about what they ought to be doing. That's my point. Okay, this next one is a great question here, because we've been talking about fine china, and this is a fine china question. Mm-hmm. Fine china. You see where it says fine china right there?
Yeah, 89
All right.
years old.
My mother is 89 years old. Okay, now listen to this. Now listen carefully now. My mother is 89 years old, and all her sisters live into their late 90s, and the mother lived to 101. Now, mostly when you talk about 89, you think they're on their last legs. You remember what I used to say about George Burns at 89? What did I say? George Burns was seeing Las Vegas showgirls until he was 99. I used seeing better.
All right. I remember what you say about
George.
At least he could see.
All right. Yeah, seeing. I changed it. She has not had a mammogram in 20 or more years. Now, this is a thing we hear all the time. Her dog jumped up and hit her on the chest, and she found a lump. Thought it was the dog bruising her chest. It didn't go away, so it was just biopsied and is infiltrating ductal cancer, and the hormone receptors are both high, whatever that means. Does she need to see a surgeon or an oncologist? Well, at least he knows she needs to see somebody, doesn't she? Put up that first picture of that nice lady there. You got that picture there? That lady is actually 89 years old. She's not my patient, but she's from a course on breast cancer in the elderly. The picture that she's showing is a real nice woman sitting there with a needle in her arm, got a little cap on, getting chemotherapy, and she's clearly a nice little old lady. You can pull that down. Well, that nice little old lady's got a lot longer time to live. And here's this next, you got to have one of these, right? So put that next one up that's got that linear graph in it. Now, there's pretty colors there, but this is the incidence of new cases of cancer and death by age. And so breast cancer is not too common way back here, and here we got people in their late 80s, but this number there is the deaths. The death rate, you can pull that down now, the death rate of breast cancer for elderly women is high, and then you want to know, is it high? Why is it high? Well, number one, when you're studying people in a research protocol, now, so Ray does a lot of research over there. When somebody dies, all-cause mortality goes into the death rate. So when you're studying a group of people that have breast cancer, and the husband shoots the wife that's on the experimental protocol, she's a death. Mortality. She's a death on the experiment. It surely wasn't the drug that killed her, because her husband shot her, right? So those statistics are a little bit scary. Except that elderly women frequently are not given the thorough evaluation that it takes to best tell how they should be treated. So pick up the next one. There's going to be a little more. There's going to be a little more pictures here because this is an exercise that has to have some brain. So breast cancer in the elderly has some very favorable features, as this one does, and the unfavorable things are you don't know how long the patient's going to live. You don't know how many, do they have brittle diabetes or strokes or angina or something? Are they frail? So those are patient-specific characteristics that have nothing to do with the cancer. Over here, generally the cancer in the patients is very favorable, real high estrogen receptor positivity. Pull that down. Got it down now, Emily? Well, that's what that meant about the hormones are both high. Pick up that next one. This is kind of easy. So when you've got breast cancer in the elderly, what's the first thing you're supposed to do?
Estimate life expectancy.
Estimate life expectancy. So that brings us back to George Burns, doesn't it? Now, it says, see the available tools above. You can pull that down now.
Now, I will say this. Now, I know we're talking about breast cancer, but I am well aware of senior cancer, we'll just call it that, cancer in seniors, to where doctors
your own family. We talked about that.
Start looking at the health. All right, what's the health? When you start talking about clinical trials, what to do, what medications, what can you endure?
Well, go on and tell them. And you're talking about your mother.
Yeah. I don't care. We've done it. But my mom, double hit lymphoma, and
now what's double hit lymphoma? Big deal, right?
Yes.
That's really bad.
And
okay, really bad.
The thing is, and I'll just say it quickly, I learned a lot of stuff I didn't want to know.
Yeah, you know what I'm saying? You're better off for it, though, aren't you?
But at that time, and my sisters, were there, but I was involved also, and they were more in tune with it. But they went through, and I remember hearing, what's mom's health? Let's go through mom's health. What can you endure? Because when you're at that age, and she might be watching, so I don't want to give her age. She's not 89.
What did I tell you? Treat her like she's biological age. It's going to be tough.
Yes.
And the chances that she's going to get through this and be well are infinitely bigger than the chances that she's going to die of the treatment.
Absolutely.
In other words, the hazard-benefit ratio is on the benefit side. Yes, there's hazard, but the hazard-benefit ratio is on the benefit side.
I would say, as being right here, listening to this at 89 years old, treat mom.
Well, she's also got good genes. Now,
right, exactly.
That's how we started.
Exactly.
She's got the right parents.
Mother lived to 101. So,
all right.
Be prepared for the treatment. It could be tough, right? But
all right,
not to go on there.
All right, but here's another one of those. That's the endometrial cancer one, not the breast cancer. So here's the breast cancer one. So there you go. Let's put that one up there. So what this tells you is that in these patients of this age group, once you know that biologically they're okay, this is confined to the breast, it's estrogen and progesterone receptor positive, you can pull that one down now. The treatment is going to be the same algorithm, and that is you got to do something locally, and do you not have to do something systemically to prevent recurrence? Well, I guarantee you that this woman with the estrogen and progesterone receptor positivities won't have to take a pill. I can tell you 95% predictability without having seen it. This is not going to be too big enough to where the surgeon's going to want to take off the breast. He'll sample the lymph nodes. She'll be in it. She won't even spend the night in the hospital. Be an outpatient surgery. Maybe they'll let her stay a night because she's 89 years old, but basically she wouldn't. She's going to heal from the surgery in 2 weeks. She's going to go to physical therapy to make sure her shoulder still works real good, and she's going to take a pill. So she's going to have a month, and then she's going to take a pill, and she's going to do just fine. Now, That next question, the end of the question, does she need to see a surgeon or an oncologist? And Ray answered that. But Ray answered that question before when he talked about the GYN oncologist. Mm-hmm. So we have breast cancer teams. You've heard that right.
Yes.
Okay, so what she will see, if she sees me or she sees the surgical oncologist, the same thing's going to happen. There'll be a medical oncologist, a surgical oncologist, and a radiation oncologist who will discuss her case, and they'll decide, yes, she should have radiation, or no, she shouldn't. And if they do a lumpectomy to preserve the breast, the answer is yes, she will. If she decides, when in doubt, cut it out, or just get it off me and has a mastectomy, then she may not need radiation therapy. So all three will talk, then they'll give her options, and they'll say, Mrs. Jones, this tumor seems to be confined to your breast, but it's pretty big. You can either have a mastectomy and they'll take a couple of lymph nodes, or a lumpectomy and they'll take a couple of lymph nodes. And we believe, from what we know now, it might change when we get to surgery, but probably won't. You'll have to take a pill for 10 years. And if you keep the breast, then you're going to have radiation once a day for about 6 weeks, but your breasts will be symmetrical and they'll still be there. But if you want it off, you're not going to need radiation. And the patient will make the decision, Ray.
Yeah.
They'll get enfranchised as to how they should best be treated.
And they'll look at all angles and they'll make their own decision.
Right. And I would say that 98% of patients in this situation today, or 95%, have a lumpectomy. But there are still people who don't want to take the COVID vaccine, right? They strongly feel that they don't want to take the vaccine. We'll switch that over. There are people who, if they've got cancer, they want it out. It doesn't make any difference if there's an option to not take it out. They want it out. Well, if they want it out, I tell every patient, I'm treating a patient, not a chart. And Ms. Jones, if you want to have a mastectomy, we're going to get you a mastectomy. The next question is, you're 89 years old. Would you want to have a reconstruction when you have the mastectomy? That's what you have to consider before you do the mastectomy. Most 89-year-olds would say no. But yesterday I saw a 75-year-old woman who just married a 50-year-old man. She might want a reconstruction if she had one. So that, again, is a personal decision. And what does it go back to what Ray says every time? Every patient's different. They need to sit down with their doctor, and they need to come up with a plan based on their value set, what's important to them, and have all the information. So I think your mother's in good shape, and go on and let her see the surgical oncologist, the medical oncologist. It never starts with a radiation oncologist.
I want to talk about the dog that saved your life, but echoing what Bill said there, he shows you frequently what we call algorithms, which are decision trees of things to check as you work through your decision process. But nowhere in those algorithms are you locked into doing what that says. And if you are of the mind that you've got to follow an algorithm in order to take care of a patient, you're in the wrong profession. I'm sorry. And there are some people there. It's just not the way you practice medicine. The dog. So he jumped on her and caused her a little bruise or hurt her a little bit, and she started checking herself, and she found the lump. She should have already been checking herself. Just because you're not that age, you don't stop seeing your doctor, and you certainly don't stop doing self-breast exams. Okay? And it's men the same thing. So, I tell people to inspect their bodies. And I had a case in here just that Bill had sent me, a primary care case now. Fella had a lump in his leg. And it got a little bit tender. But I don't think if it got a little bit tender, he would have bothered with it. But thank goodness, sooner or later, he got it looked at, and they took that lump out, and it was a bad sarcoma, and they had to do an even bigger, wider resection to deal with it. So check your body, and if you find something that's that abnormal or getting bigger or getting painful, don't sit on that. Go get it checked. So her dog saved her life.
No, now listen. Now he just came up with one of my favorite things I talk about. Remember, my right hand should look like my left hand, only a mirror image.
Yes.
My right eye should look like my left eye, only a mirror image. So if the right breast and the left breast feel different, even though it's not clearly a lump, somebody needs to look at it. Man had a lump in one leg and didn't have it in the other, and he ignored it for a while. So if you got the bump there and it didn't go away in 6 weeks, like, I might bruise myself, you want to jump on it a little quicker, don't you, Ray?
Yeah. And I think people don't want to be a hypochondriac, and they don't want to come in for every little thing, and that's true. But, you just be observant of your own body, and if it's asymmetrical or it's changing in size, shape, color, or it's getting tender, don't fool around.
All right, now I know you got 2 questions that came in this morning before we got started that relate to last week's discussion of COVID. And this ain't a COVID program, but if you look real carefully at these numbers, the incidence of COVID death, for example, in Fannin County, there have been 61 deaths and 2,228, quote, cases, end quote. That means positive tests. So that death rate has gone down a little bit compared to last week. But yesterday, there were 0 cases and 0 deaths. That's the first time that's happened since way back last March, I think. So the COVID case rate, hospitalization rate is falling. That to me means, and the death rate's falling, but if the hospitalization rate's falling, that means that you can predict that the death rates are going to continue to fall, even though, as Ray just got through saying, a lot of states and stuff are clamping down harder right now than they were before, which I think is idiotic, because they're worried about the, quote, London, South African, and the other spikes. We've already tried to put that away last week. But anyway, the COVID situation, I believe, is somewhat improving. The news of the week: CDC and World Health Organization create threat levels for COVID variants. That's like the terrorism threat level, and that's the big stupidest thing I ever heard of in my life.
Thing. It's part and parcel with what they've been doing. It's just creating fear.
Yeah, it is.
I was checking the graph, and I sent it out to you guys. There are over 1,500 variations of COVID. 1,500. Okay? You don't know if one of them is going to be bad until it becomes bad. You can't look at the mutation change in that and say, oh, well, that was going to be a bad one there. They have no idea. But they can look at each and every one of these DNA and RNA sequences and say, yeah, that one changed a C to an E, and we don't know what that means. So for anybody to be running around saying, well, you got to be worried about these variants, we've had variations all through this.
And that's a common cold.
Yeah.
All right, go ahead. Get the paper.
Well, I do want to say this. Always, I like to get right in there. Thank you, Georgia Cancer Specialist, affiliated with Northside Hospital. I have a real quick question when we close, and I know we got to move along. I have two questions, and as the conversation, we'll say the conversation that I'm hearing is surrounding the vaccine and taking the vaccine, the single shot, the double shot. Should I? Am I okay? This question came in. I had COVID-19. I had COVID-19 exactly 1 year ago this week. I went to the doctor 3 days ago for an antibody test. They called me yesterday and said, yes, I was positive for antibodies. Should this replace the vaccine, or will I need it in the future?
Two answers. They're based on time. Right now, when there's inadequate vaccinations around, it's perfectly fine for this person to wait. They are essentially immune, okay? And so for them to take someone else's vaccine right now is a little bit selfish, in my opinion. So you'll notice Senator Paul, he had the illness.
Right.
And they keep asking him, well, are you going to get the vaccine? Are you going to get the vaccine? He said, look, I'm immune. Somebody else needs the vaccine right now. They can have the vaccine. I'll decide about me later. Probably for him even later, he's going to say, as long as my antibody tests are good, I'm immune. I don't need the vaccine. So, yeah.
I'm going to stop you there.
Yeah.
But we don't know that yet.
We don't know
so
that
there's
yet.
going
So
to
could
be,
you retest for antibodies every 90 days?
No, the antibody's worthless. I'm glad they did, but she should be relieved. But we're going to know more in 6 months than we know today, as I said last week. What's true today may not be true in 6 months. So I would tell that patient, if you're a healthcare worker or a frontline frontline person,
Or you have an elderly person you're taking care
or
of.
whatever, you're recommended after 3 to 4 months to get a vaccination. That's not the general population.
Yeah.
That's people who are out there. So we don't know the answer, but the answer probably is someday you might need a vaccine. But right
this
now,
is a year later. I mean,
I understand.
No. We're talking about in this situation with inadequate vaccines around, and we're still trying to get all of our seniors fully vaccinated and moved out.
Wait. Don't get in line in front of somebody in a nursing home,
Right.
or don't get in line of somebody that's overweight, that's 40 years old. Let them get the vaccine. You've got a reason to be calm for a while.
okay.
So I'll say be calm for a while and listen to us each week, and we'll tell you, and don't pay any attention to what Dr. Fauci tells you.
Now, can you get the antibodies test anywhere?
Yeah, your doctor can order it. Now, I would caution, and hopefully the doctor's paying attention. There are labs that are doing good work and labs that are not doing good work. So,
Yeah.
Okay.
We could tell you could use Dr. Marlowe's lab, but that'd be a
All right.
payola.
conflict of interest.
So this is another one that come to me yesterday. We're having a discussion, and I agree. I agree with this question. I mean, the person that brought this question to me, because what I'm saying out there, we hear herd immunity. There's still confusion around the numbers that we get reported on different things. So why aren't natural immunities being counted in overall herd immunity numbers? Fauci seems to deny all we know about pathogen immunity.
Okay, here we go. This is really kind of easy. They're not doing the population test. You remember many months ago, I gave you a story at the Costco in Greater Manhattan where 3,000 people went in Costco in one day, and they got them to let them prick their finger, and 14% had antibodies. That's a population study. Until you go into a population and then measure the antibodies of people who have not been vaccinated and have not had the disease, that's what they're talking about. You don't know what proportion of people had an asymptomatic case, were never ill, and gained immunity. That's the herd immunity that is from the herd and not from having the shot or the illness. So that the herd immunity includes those that have had the COVID vaccine. It includes those that have been ill and diagnosed, but probably the largest number are those that never got sick, got the virus, didn't know they got the virus, and have antibodies. So we are right now not doing population studies.
And we're only speculating about what that is. I mean, there's speculations as high as 30% have had asymptomatic spread without knowledge of it. Let me follow up on Bill's answer there. And this is, I watched the exchange between Dr. Fauci and Dr. Paul yesterday in the Congress.
They need to let Dr. Paul have more time at the podium, don't they?
And this is immensely frustrating for me. So let me try to bring it down into lay language. Bill talked about risk-benefit analysis, okay? And we do that on individual patients. We should also be doing it on anything that we apply in medicine. And in this particular disease state, for whatever reason, it was not done. I have not seen anyone ask Dr. Fauci et al., all the people that are around him, what is the risk of your treatment? How many people are you hurting? How many students have not gotten an education? How many businesses have been destroyed? How many people are in desperate straits that are taking more drugs and overdoses? What is the risk of your treatment?
Teenage suicide.
Suicides. No one has asked him that question. No one's held him to that standard, and I don't know why we don't. We, as physicians, we're trained to do that. He somewhere at some point in his life was trained to do that, and no one's holding him to it. This disease, now that we know a lot about it, has this almost 80-20 split we talk about. It's not a precise number, but 80% of the deaths are in this population of folks that is very defined, okay? The rest of the folks are in a flu risk pattern, okay? I mean, flu kills people. Flu makes people really sick. If you've got other problems, flu can hurt you worse. But we don't change our whole life. We don't change the whole culture over flu. we know that there's a population of folks that are at risk for COVID, more risk. Now, they're not all going to die if they get it. We know that 96% of them live through it. Okay, so but it's an increased risk in that population. So all of our treatments now and all of our social decisions and cultural decisions should be based upon what is the risk to that population. We've said it time and time again on this program. How do you protect that population and then let everybody else do their thing? This is not novel thinking. This is not radical. It should not be radical thinking. This is medical common sense.
Which is why in the world are kids not in school?
Why are they not in school? Why is there any place with an economic shutdown? Why in the world would you tell somebody they got to be inside in their own house at night, where, by the way, you share the virus? Why would you not go out in the sunshine? Why would you not spend time on the paths or on the hikes or getting exercise? This is absolute nonsense, and it is almost scary to me that our populations, our citizens are not saying no and hell no. You don't get to tell me what to do. I'm a free person. Well, that's my rant.
Well, they're doing a pretty good job of it in Florida and Texas, Georgia.
Well, I'm watching what's going on in Florida for spring break, and there's this crazy thing happening down there. People are making their own decision.
Yeah, what did I tell you last
it's
week?
Crazy as can be. They're making their own decision.
That picture they showed.
If they want to go to the beach, want to go to the sand.
That picture they showed, though, those people were being baked. I mean, the sun was all over them. You can tell me that virus is going to live very long?
10 seconds.
Well, I want to say,
Might be 18.
I want to say one of the things is we're out here and we get so much information and we don't know. I'm gonna put it like this: we don't know what to believe, and not really attacking the CDC, but now the CDC says, oh, kids can be 3 foot apart.
That was all a make-believe number to start with. With the 6 feet, there's no science behind that. There's no science behind 3 feet. It was just, okay, let's make up a number.
Well, there is a science behind 6 feet. It's not very good science. And that was that. You've seen that picture, though, where the rapid photograph of the guy sneezing. So that's 6 feet came from that guy's photograph.
Do you know what 3 feet apart is? That's where the desk is now.
Yeah.
The desk is here, and this one here, and there's an aisle between it. The kid is 3 foot apart now, so I mean, before.
The recess, though, when they get behind the gym and start kissing, is closer than 3 feet. You think you're going to stop I'm serious. You think you're going to stop third graders and fifth graders and stuff at recess from finding some way if they're. I mean, kids are going to. I mean, some of them
wrestle.
they're going to wrestle and tussle. I mean, I just think it's stupid. And as I said last week, my grandson is wrestling 9-minute. 3-minute things in a high level with kids, and he can't shake hands after the bout.
Bill, I need to find out where this resource or where this quote was from, and it was a military quote, and I think it was from between the First and Second World War, one of those where the lieutenant or somebody said, "Look, I've got a disciplined group of military men here, and I cannot quarantine them for more than a week without riots occurring. Okay, I just can't. You can't do it. And to expect or think that you're going to quarantine everyone, a nation of people, when you can't do it with soldiers, is ludicrous. And yet we rolled it out. All you people go run hide. All of you stay to yourselves. And when the results were that it didn't make any difference, and people were surprised."
Yeah, look at New York. It's getting up more and more people. Anyway, we're not.
You got a closer or something you wanted to say?
No, I'm dry today. I'm sorry.
Okay, good. We'll leave you there. And you?
I like my tie.
Yes, you.
I like the jacket. I got the leather memo this morning. But I'm not going to L.A. like you. So.
Yeah, all right.
Okay. Dr. Raymond Tinman and Dr. William Whaley, we thank them so much every Friday for being here. This is our Ask the Doc segment. You can find this segment on FYNTV.com. Look at Ask the Doc. All of them are posted there. You can share them with your friends. Share that page with your friends. Everyone's loaded. Also, information about how to contact Dr. Whaley and information about Northside Hospital. FYNTV, Ask the Doc. Everything is there. And please share your questions or ask your questions. Info, INFO, at FetchYourNews.com. Put in there, Ask the Doc. or on our social media pages. So don't hesitate to send your questions. Always thanking Georgia Cancer Specialist affiliated with Northside Hospital for this segment. Gentlemen, thank you very much. We appreciate it. You head for Lower LA. I don't know what you're headed for with those with those socks. I don't want the people to say.
That's the way physicians dress now in the mountains, and I think people should take a close look. This is a very, what do they call this, elegant casual or something. I'm the only guy I know, because of my senior age, and my dad was a Baptist preacher's son, that still wears a tie.
Good.
Yeah. Right. Do you know anybody that wears a tie to work every day besides me? No.
4 days a week, I do. Monday through Thursday, I do.
Really?
Yeah.
And when he's preaching.
Yeah. And we got to go, man. All-star political panel right after this.